for joining today's session, FAQs on how to communicate with your healthcare team. I'm Quinn Young, Chief Mission Officer at the Multiple Myeloma Research Foundation, and I'm joined by MMRF founder, two-time cancer survivor, and author of Fatal to Fearless, 12 Steps to Beating Cancer in a Broken Medical System, Kathy Giusti, as well as Erin Mensching, who's our Senior Manager of the MMRF Patient Navigation Center. They've agreed to answer questions about optimizing communication with your healthcare team that we received from patients and caregivers after our recent webinar on the topic. And then, of course, there's always the opportunity to join the chat and insert some questions and comments that you may have of your own. So we'll start with a theme that came up quite a bit in the webinar questions. Kathy, you spent 40 years in the healthcare space, first as a professional, then as a patient still, and then leading a foundation. Most patients don't have that background. So what we're hearing is patients are hesitant to appear, say, confrontational with their healthcare team, asking too many questions, but they have a right to know, have their questions answered, but also make sure that their needs are met. So for those patients who haven't dealt extensively with the healthcare system, what is the best advice you have for, as you said, they get an average of 16 minutes with their doctor. How do they maximize that time?
That's the number that always blows me away. You get an average of 16 minutes. And like I've said before, you get more time on your initial consult with a doctor. They actually book more time. But as you move forward, it really is around 15 or 16 minutes. So the advice I give people on this is, number one, whenever you walk into your clinician's office, there's a lot of people you're meeting along the way. You're meeting the administrative support. You might be meeting a physician assistant. You might be meeting a nurse, an infusion nurse, and also you might be meeting your doctor. So what I think patients get in trouble with is giving the wrong question to the doctor or not giving the right question to the PA or the nurse or the administrator. So I think it's really important to sit down and say to yourself, okay, I've got 15, 16 minutes with this oncologist. What is it that I want to ask my doctor that my nurse or the front desk can't answer for me right now? And once you put those questions together, you have to prioritize them. So it's like, question number one, I need to have this question answered, 2 and 3, and get through that and absolutely know you don't want to leave that office without the information on those specific questions. Number 2 is you have to do your research ahead of time. So you just want to go in on the areas that are most important to you and say, is there something that you might be able to find when you do a little research off Google or other places and say, okay, I want to know more about a certain drug. I want to know a bit more about a certain test. Well, go in and see what you need to know, and then maybe look for the latest abstract on that information, or look like an NCCN guideline might be helpful. Those things become really important because it shows you're not just saying, my friend chatted with me about this and I want to come talk to you about it. It has to be dedicated to your care. The third, and you know I'm a huge believer in this, is finding a navigator to help you. So obviously navigators can be found the MMRF, especially when you're focused strictly on clinical issues and trying to get through the journey, also at academic centers, but we can talk about navigators a little bit more in this program. And then finally is, if you're sitting down and talking with this doctor and you're really trying to get through to them and you've taken all these important steps and they're not getting any help, then you definitely need to go get a second opinion. And then the final thing I often say to people is, it's sometimes good to bring somebody with you. If you have somebody around that can be another set of eyes or ears, it's great because then they can answer a question, or a thought while you're still gathering your own thoughts and taking critical notes down. But you have to look confident and you have to know what you want, and you have to say, I'm not leaving here without this information. And by the way, our doctors are phenomenal, but they are also getting paid. This is their job. I mean, it's what they're supposed to be here doing, is answering your questions.
And Erin, you end up spending a lot of time preparing patients for visits. Is there anything else you would add or you find that's very specific to myeloma that has been helpful to patients? Oh, your audio, Erin. Okay. While she figures that out, there's a couple of examples, Kathy, that came up that are more specific to just a specific one visit. How a patient, you kind of address this in terms of when to get a second opinion, but say the doctor, a patient's asking for another bone marrow for testing, or wants to understand more about their risk or clinical trials, and the doctor is very hesitant to do that. Do you have advice for patients on the most effective way to broach some of those topics where a doctor may have one view, but the patient, before leaving and getting that second opinion, how to really get those requests through effectively?
Well, I think it does go back to the same process in doing your research and knowing what's going on. I feel like if you're a patient and you're trying to understand what clinical trial, for example, let's just use that example, is right for you, and you've heard probably somewhere through the grapevine, it could be an MMRF webinar or something like that, that there are some new opportunities going on in trials. In a situation like that, because clinicaltrials.gov is tricky to work with, that's where I always say to a patient, you're very fortunate in myeloma to be able to call the MMRF and talk to a navigator, because then they're sitting with you face to face while you're on clinicaltrials.gov and going through and sorting through the trials. What you don't want to do is walk into the doctor's office and say, I see these 50 trials. Tell me which one is right for me. Because in fairness to the doctor, they have such limited time with you. They want to be able to answer a yes or no question. It could be, I see these three clinical trials. I'd like to know which one is best for me coming down the road. And so I think you have to be very specific in how you're asking the question, and very specific in terms of knowing what you want. And then again, you and I have had this discussion a lot, and that some patients are very focused on quality of life, and they don't want to take a certain combination of that has really, big side effects associated with it. And others are like, no, give me everything you got, because I want to buy as much time as I can. And I think those discussions are really important to have with the doctor as well.
Erin, are you back?
Hopefully you can hear me.
It's very low. Maybe try a headset. And then another question that came in that we did, Kathy, cover on the webinar is how best, but for those who weren't on it, how best to ensure that communications between doctors who may be at different centers or maybe managing two different diseases, just, even your anecdotes about, managing the myeloma with the breast cancer, and what's some really good advice for patients on how best to do that?
Yeah, I think just as a reminder to everybody, in my personal situation, it was that my multiple myeloma is treated at Dana-Farber and my breast cancer was being treated at Mount Sinai. And the example I gave was that in my situation, the information was not shared in the portal. Like they just weren't talking to each other in the portal. So when you have a situation like that, it's on you as the patient to get the contact information for each of these doctors and to set up a call, and then to make sure you're on the call. So in today's world, I would just be like, okay, I'm going to set this call up and put them on an email and find a time that works with both of them. It takes a fair amount of pushing to get them to do this, but I know from experience now, it is so important. And again, because if I had done that well before my double mastectomy, then I would have known to take bigger precautions than I did for that surgery, and I would have avoided probably 6 to 9 months of pure aggravation. So yes, get them on an email together. You get their email addresses from the front office and get them talking. All it takes is one call. And honestly, if you frame the call for them, this can be done in 15 minutes, but you'll get much better care. Don't rely on all the portals talking to each other. It's great if they do. And like I said on the last call too, if you can stay at one academic center or within one oncology practice, that is a win, because having all your records in one place makes it easier on you for sure.
Are you back?
Can you hear me better now?
It's still really low.
Oh, okay.
Okay, there you are. There you are.
Can you hear me better now?
Yes.
Yeah.
Yes.
Oh, good. Okay. I'm sorry I didn't hear the last few minutes, but I did have some great things to say before.
Yeah, please, from the topics of preparing for how you help patients prepare to maximize their doctor's visits, how you help them perhaps confront some topics that are difficult, or when the physician might be resistant about doing MRD testing or talking to them about risk or clinical trials? How will you help patients navigate some of those conversations?
Yeah, so the first is, I think Kathy had already mentioned this, but so for patients to know that they are worthy of having these really totally amazing conversations, even if they're uncomfortable, but to make sure that you ask the questions, even if you feel like you don't have enough time, to go in there with a really clear intention. I think Kathy had mentioned this too, but to set the intention first, to look prepared, be confident, and then have your list of questions. And one thing I wanted to add is to ask open-ended questions. So instead of saying, do you think I'm relapsing, or do you think this is to be expected? And the doctor just says yes or no and kind of just moves on, but to really ask questions that expand the conversation. So it could be, can you offer me some tips on how to live with this insomnia or some of the side effects? So that will hopefully buy you some more time. That's one of the tips that I had wanted to mention.
Yeah, I think it's important, even with the open-ended, that there are very specific topics to say, hey, I'm going to walk in there and in my 16 minutes, I want to get these 3 things done, and almost script it in advance, because then time is lost when you're trying to remember things. Let your caregiver know what your objectives are. Sometimes they can jump in and say, oh, didn't you mean to ask about this? Or I've noticed that, there's this side effect emerging, and that can be really helpful too, as Kathy mentioned, to have someone with you, not just listening, but also to share what they're seeing.
Definitely. And share with the nurses and the nurse navigators that are part of the team, because if you haven't already mentioned it to the doctor, or maybe you ran out of time, they can help, maybe get a call back for the rest of the day, or tell you how to message if you don't already know how to do that, the internal messaging system.
Well, and to build on something that Kathy said earlier and you just referenced, is I think that some discussion on what are appropriate questions or information to share with the doctor versus the nurse versus, say, a navigator, because it's so complicated to have a whole team. It used to be, okay, you need to get to a specialist in myeloma, a hematologist, oncologist. Now you need a whole team around you. And I think a lot of patients don't necessarily know who's on that team and what their role is.
I agree. Yeah. I feel like you have to, again, when you're sitting there putting your plan together, that's where you might be able to sit down with the PA and the nurse and say, okay, just tell me exactly what this is going to look like and lay it all out for me. And they're usually really, really good at that. I don't think you have to take your doctor's time to do that when you're much more interested in what he or she is going to say about your potential treatment options and where you're headed. I think the other question that often gets downplayed is when you actually are really curious about if you do relapse. Maybe you're doing great, but you just want to know, if I do relapse, what should I do? And they all, at least for me, I always got the answer of, we're not there yet. Let's cross that bridge when we get to it. And it drove me crazy. So I used to say, I really want to know, like, in today's world right now, if I relapse today, what would you do? And I would have to push for it, but at least I'd get an answer. And then I could do some research on that potential protocol, because, that drug combination, so that I would know what was ahead of me. I think you do your best work and your best research when you feel fine, not when you're worried about a relapse or a new diagnosis. So timing can be everything. And Anne, let me know if you think this is a good time to talk about the different areas of navigation, because I think that's important too.
Before we do, Erin, is there anything you wanted to add just generally about I'd say the non-navigator team members, before we dig into that term that's used very loosely and can mean a lot of different things?
It really depends on where people are at in the journey, but I have witnessed over the years that we really do get so many calls from people who are feeling well. They're in remission, or maybe they've been smoldering for many, many years, and there's so much to learn. So they call and they want to make sure that they stay the most up to date on their information. So that is a good time to gather information. So asking questions and making sure that, that patients know the priority of that visit and understand the different roles of their whole team. Yeah. And I'd love to talk about nurse navigation too, because that's my passion. So
yeah, there's, I feel like I go on so many different organizational sites there's companies, Kathy, you mentioned at the beginning, now that there's insurance reimbursement, there was a lot of these organizations coming into the space, but the term navigation is thrown around a lot and means a lot of different things.
Mm-hmm.
I think it would be helpful to help kind of describe the different types of navigators and what type of navigator you go to what for.
Yeah, I think this came up, and we talked about this before. This came up quite a bit under the Biden administration when it started to be clear that there would be potential reimbursement for navigation. And again, in healthcare, it's inevitable that people do follow the money and the reimbursement. It's how the organizations stay alive. So in that situation, there were two different levels of reimbursement. One was for a general navigator that did not have a nurse background, but knew enough about the journey and potentially even community services that the patient could benefit from. And then the second was professional nurse navigation. And so there was a lot of training going on in both areas. American Cancer Society was doing a fair amount of that training, for example. So now fast forward a bit, and the different groups that are really starting to put navigators out there are, number one, organizations like the MMRF, the foundations. But not every nonprofit or research foundation has navigators. But the myeloma community is so lucky that the MMRF has taken this on and literally funds professional nurse navigators, because it's really unusual and it's phenomenal. And so I find that I'm constantly referring patients to the MMRF navigation group because they're up to speed on anything going on in clinical trials, new treatments, diagnostics, you name it. And then I think the second area that I always, recommend to patients is if you are at an academic center, they are building out navigation as well. So some of them have, good navigation. You just have to check into it. Erin mentioned earlier, and I wanted to talk about this a little bit more, is will you get the continuity that you're looking for in the navigation process? It's really nice if you can work with one person that's walking you through the whole journey itself. So you have to ask the academic center about that. Some of the community hospitals have it if they're bought by a big, large hospital group, and the hospital group is offering it. So that's another place that you go. And then finally, there are groups like I work with Time Care. That's a group where it's done through the insurance company and the large oncology practice. So in that situation, you do get continuity, and they're more about the whole patient, which is more the psychosocial, financial, finding community resources for you. And that can be really helpful too, but you have to make that extra call just to make sure that your insurance is covering it. Well, if you call the MMRF, you can just get Erin on the phone and she can help walk you through your treatment options, which is terrific. So they all have their pluses and minuses, but navigation's definitely a place that I feel patients and their caregivers need to understand and pursue.
Well, a team of 3 clinically trained myeloma nurse navigators. So they do have all the myeloma background, but not only myeloma background, but they have the knowledge of how the different organs work. And so when we're talking about side effects, and we do get these questions about going over the labs in very high level detail, we can kind of understand the different systems that are part of myeloma, the disease process. So that's why I really do think we bring a lot of value being clinically trained nurses here. And in terms of the continuity of care, our great nurses, we talk to people right at diagnosis, or maybe even sort of when they're thinking they may be getting a diagnosis and they call to talk about their labs and some concerning labs, but maybe they're just not quite sure yet. So we do a lot of hand-holding from the very beginning throughout the whole journey. So we talk to people over years, and then they call us about a relapse, or maybe if they're thinking they're relapsing. So we stay really, really up to date. We go to many wonderful conferences that help educate us on all the current research that's going on, as well as the new treatment combinations. So we really do. We're here. We're lucky that we're here. We could be here for people, and not only just patients, but for their whole entire family.
And so a comment did come in from someone asking about how to contact you. So we can share the 800 number. But just, Erin, if you can expand a little bit, you touched on this a bit, how you work with patients. He said, do they interact with my oncologist, or just prepare me to ask the right questions? I would touch upon, because you don't directly interact with the oncologist, but with clinical trials, for example, you are in touch with sites. So some of the specific examples of how you work with patients, but then also with centers.
Yeah, so well, when it comes to clinical trials, we do reach out directly to sites. So based on disease status, we look at, what treatments have you been on before? What kind of trial are you looking for? Many people don't even know what it means to join a trial. So we go through all the different phases, what it means to travel, insurance coverage. We get that question a lot as well. And then we help reach out to identify different sites that are available. We have really good relationships. The MMRF has built amazing relationships with many of these top centers over many years. So we reach out directly and make contact. We handhold pretty much in any aspect of, looking for a treatment, looking for a trial, or finding different resources. And then if someone is newly diagnosed, or if you're just sort of wanting to talk about a treatment you're on, we give you questions to ask. We talk about, from a non-biased perspective, we'll say these are, to be expected side effects. We talk about the ones that are more serious that you will need to talk to your doctor about. And again, just really empowering patients to know that they're worthy to ask their questions and to expand on that time that they have with their team.
And I think, one difference between you as a trained nurse versus lay navigators that Kathy described, or sometimes even patients are trained to be navigators to help other patients, is you can also recognize right away if there's a medical emergency and be able to direct patients to get in touch with their doctor's office or even call 911 if needed. And that's a really important piece, because there's a navigation piece, but then there's really that clinical piece that you're not treating a patient, but you can give that guidance to say, this is what you really need to do right now.
Mm-hmm. We've got several medical emergencies before, so that is a benefit to having that knowledge on our team.
And to go back, there's been a couple of two patients commenting kind of on both ends of the spectrum. One is MGUS, so not even a patient, really an individual living with MGUS, and then a patient who's moving to fourth line treatment. And both of the comments, I would suggest, warrant second opinions, or at least asking about both. So for the fourth line treatment, back to Kathy's point, what are specific options? But where the Patient Navigation Center is here to help facilitate another opinion if you're not getting what you need from the oncologist. And then on MGUS, Kathy, we were just talking about this earlier about making sure you're having the right observation or the right frequency of visits with your doctor. So maybe comment a little bit on that, and the disconnect between what the patient wants and what the doctor's saying.
Yeah, I found this, it happened to me early on when I was smoldering, that when I was, pretty stable in smoldering, they were very kind and like, you don't have to come in that often, but I really requested to come in every 3 months at least in my smoldering situation. In MGUS, you don't have to be monitored quite like that, but I do feel like no matter what they're saying, you do want to be monitored. And so don't start to get lax just because they're saying you're doing great. You want to be on your game at all times. And then I felt it again, after all my treatment and trying to decide okay, how much do I need to see the oncologist? You're on maintenance therapy and do you need to see them often? But, things happen and you still have a lot of questions following up from a stem cell transplant. I wish I'd spent more time with my doctors then. I've talked a lot about how I did go into depression. All of a sudden now I didn't even know this, you're now in menopause. There's things that happen to you. You don't have an appointment to go talk with somebody. So I think scheduling them is critical. And even now, this is one of the questions, the areas that Ann and I were talking about, is for someone like me, where I was more prone to a secondary cancer because I'd had radiation, all these things. Again, I wanted to be monitored very closely by a breast cancer surgeon. Thank God I did. They found it early, but I do the same thing with the dermatologist. Like if I've got squamous cell, I want to be in there every 3 or 6 months, even though they might say to me, oh, you're doing great. We haven't seen anything for a little while. Come back in a year. I'm like, no, I'll be back, because it's, it's your life. And, It's just an extra chip, and usually insurance is going to cover that. That's always another thing I recommend is no matter what you're doing, just call the member services on the back of your insurance card and make sure you're getting the coverage you need and that you get that in writing.
Erin, you get some MGUS patients or individuals with MGUS calling, how do you typically advise them to, because we know a minority does end up developing myeloma, but we don't know yet which 20% of MGUS patients those are. So how do you typically advise them to get the best care and feel the most amount of, I guess, comfort or stability in their diagnosis?
We share the NCCN guidelines. I think there's a lot of just sort of misunderstanding about how often they need to be monitored and how often these labs should be checked. And then honestly, to say that there's a lot of anxiety with having a diagnosis of something that you just don't know is going to go this way or that way. So we do talk about psychosocial care and getting counseling. And there are organizations out there that offer free counseling. So that's one of the things that the navigation team does is we make sure that we stay up to date on the resources that are available. And they do change year to year. Sometimes there's funding for counseling and then next year there's not. But if that's, that is something that we bring up with MGUS patients is do you have support while you're in this sort of waiting period? And then just the really good education on the statistics and the research that has been found.
And then on the other end, patients who may be, through a lot of the standard options, how do those conversations go?
The standard with the MGUS or with newly diagnosed patients?
Relapse refractory.
Oh, yes. So exactly, I want to say the same thing, the well-being, and I just came back from the Oncology Nursing Society meeting, and they talked a lot about supportive care, a lot of fluffy terms, but really when it comes down to it, it's just your well-being. Do you feel supported? Do you feel anxious? Do you, on a daily basis, do you have things in your life that are joyful? So coming back to the very basics, because some people do take on the role of a patient as it's their whole entire life, and that seems so easy to be able to get lost in that. So a lot of the times when people are relapsing or if they're going through many different lines of treatment, it's scary. Time is a different aspect, and I understand that. The word time means something different for me than it does to them. So we do talk about the support, really the support of your team, making sure you have a specialist that you feel supported by and that you can communicate with. It's really, really important. Some people have more than one myeloma specialist because they feel that support when they have a bigger team. And then really educating themselves. That's the most important aspect. I think we've already said that a few times, but it's so true. It's just really getting a really good handle on the treatments that are coming to the market soon, the trials that are out there. So feeling like you're in control, that information can really help people feel empowered when they're in that relapsed refractory state.
Going back to something that Kathy said early on about being specific, going to the MMRF website and seeing what those treatments are, and really CAR T and bispecifics are the ones that are commercially available, and saying those words directly to the doctor to say, would you recommend I do one of these, and do you have these treatments? Because not every center offers them, because they do require, even the bispecifics, a short hospitalization stay, or if it's outpatient CAR T, you need to be right next to the cancer center. But they should be able to help refer you, as can our Patient Navigation Center, if indeed that's the right next step, because you shouldn't be hampered by, my doctor only administers IV oral injection products, when the next wave of immunotherapy is really, really effective in that setting.
I think that's one of the most important areas right now for all the patients, because knowing what's in the pipeline, knowing what's in clinical trial, and knowing that a lot of this is still at the academic center, it's hard to get to it. And yet it can be potentially life-saving and extend life for quite a bit. So that struggle to me is the hardest part for a patient. So again, you're looking at navigation to give you the right resources. I feel like at some point you've got the MMRF that can navigate you to the center that has the best trial for you. And the beauty of the MMRF helping you with that is that, we don't have skin in the game. It's like, we just want to find the best trial for you. Academic centers, it's tricky. Like, if you're the principal investigator of a trial, it's your job to get that trial accrued. If you're a doctor, clinical participant in that trial, it's your job to get that trial accrued. So they're constantly looking for the right patient for a trial, but it may not be the right trial for you. That's where I think calling MMRF navigation is great. But once you're at that center and now you need help, maybe you need somebody to come in and help you while you're there, you need to ask the academic center what kind of caregiver support they may offer if you don't have one. And then you also have to start reaching out to some of the local communities to see if there are people in that local community that could support you. A lot of times there's organizations that do care for the elderly or, other people that will also offer care for patients that are sick, but you've got to be on your game and looking for that kind of support if you don't have it. But I hate to have patients miss out on some of these current treatments that are so phenomenal just because their local hospital doesn't have it yet or can't give it yet.
And you bring up a good point about other resources. And I think some patients, and Erin, I'm sure you can comment on this, may not even bring up certain treatment options because they think financially they can't handle it, or clinical trials, for example, when there are tremendous resources out there. We have a partnership with an organization called Family Reach, where we help patients with costs that are not covered by the clinical trial. The CAR T companies offer pretty generous lodging and transportation for patients and caregivers going through that process. So we always advocate patients to ask, because sometimes too, unfortunately, the healthcare provider may look at a patient, think that they don't have the resources, and not even suggest that, think they're doing the patient a favor, not even suggest that as an option, and that's not right.
Yeah.
So, Erin, what are some other resources that you send patients to who are looking perhaps for caregiving or financial or transportation support? Oh, you went out again.
Well, if we don't get her back, I would say, some of the groups that I end up referring to, especially on psychosocial support, cancersupport.com, the American Cancer Society, Cancer Care. A lot of these groups have trained social workers that can be super helpful. Again, some of the groups that are under the insurance companies like Time Care will offer that as well. So I think, again, it's a matter of knowing it's almost like you're getting into a game right now, Anne, where it's knowing if navigation is a support system for you and you can get to it, who are you calling when, where, and why? And I think we're now trying to sort through that. To me, it's the moment you get diagnosed or the moment you're trying to find a trial or you've relapsed, you get on the phone with the MMRF, because we're so blessed that we have nurse navigators. And then I think based off of what Erin's comments are, is sometimes we just have to we can't do everything at the MMRF. Like, we can't stay on top of every single thing. So in that situation, we want to be the best at providing resources in the other areas like financial and psychosocial support, because we're not going to bring in for right now trained social workers. It's just, you can only do so much. And so I think that's why starting with us is helpful, but knowing other navigation opportunities can be helpful too. And the financial part is I can't say it enough, talk to member services on your insurance card. And since most of us are on Medicare, that becomes a huge issue too. You've got Medicare, now you've got to find your secondary support. Now you've got to make sure your prescriptions are being covered. Like, when I switched over to Medicare, like, oh my God, like, how am I handling all this? And, there are groups that help you decide how you want to do that. And that's another resource that you have to have. It's really important to get that coverage.
Turning you back. No. Yeah, it's not. So another touched upon this a little bit, but I remember from the webinar there were a bunch of questions about how to tap in to psychosocial mental health support at their center. And it maybe does go back to the social worker navigator, but it seems like it's still, even in this day and age, still not fully recognized. And there was an article that was published this month that a very high percentage, not surprisingly, of newly diagnosed myeloma patients do struggle with depression. So you'd think the centers would have these, but any guidance in terms of making sure that patients can tap into these resources?
Well, I think, first of all, you have to have a sense of what do you potentially think is wrong. You know, if the support is, I don't think I have anybody to talk to that understands what I'm going through right now, I think that's where you're talking to the MMRF and finding a mentor, like somebody that is in a similar situation to you, perhaps the same age, perhaps, you know, younger with children. It could be anything like that. If it's like, I just want to have somebody that gets me right now because I don't want to dump all this on my partner, my children, my family. That's one level of support. I think another level of support is I just want to be in a support group online, Zoom, whatever it may be, so that I feel like I'm in the know and talking with other patients about what they're doing. And I have a lot of resources there. And I think then there's this other one, which is, no, I actually think I'm really sad right now and I'm struggling. And in that situation, well, you've got to raise your hand and speak up and say to your doctor, I think I'm depressed. And usually I think for most oncologists, they do understand that these things are part of the process, and they're usually quite willing to work with you on that. Again, I think it's up to your discussion with them is if the medications they're giving you are enough to handle the depression, or whether you actually need to go on and seek out another medical doctor, a psychiatrist, whoever it may be, to help you through this whole part of it. I mean, I was fortunate in that I did raise my hand right away and said, I think I'm depressed, and ended up on an antidepressant, which is really important. But again, they're variable. Like what works for me may not work for the next person. So you have to try them and then start trying a different one if that one doesn't work. So that in itself is a bit of a process too. But it's important to get done.
Erin, you want to try again?
Erin's got to be dying here because she's so much to say.
I know. Well, there's in the meantime, there's a good question, Kathy, for you. Someone asked, because this relates to you, advising smoldering patients, or I would say any relative of a patient who has a family history of multiple myeloma. You went through this a few years ago, but how do you advise other families?
So families where multiple myeloma is in the family, or somebody is actually smoldering, or both?
Well, it sounds like I would say both. The question was specific to a smoldering patient who has a family history of myeloma, but I would also say just in general, if you have a first degree relative with myeloma.
Yeah. So I think this is really important. My grandfather, and people don't know this on the line, but my grandfather had multiple myeloma and my grandmother had breast cancer. And ironically, I ended up getting multiple myeloma and my identical twin sister got breast cancer. And then I got breast cancer. So I tend to be a little biased, thinking that, there are genetic predispositions to some of these cancers. And then along the way, something happens to you environmentally. Otherwise, why would I have multiple myeloma? My identical twin does not. We've lived, slightly different lives. And so I'm always saying to everybody, you have to know your family history. You absolutely have to know it. It doesn't mean that you're going to get what somebody else got, but it's really important that your primary care doctor or internist knows exactly what's been in your family. And so I think that's critically important. And then, yes, if you are a smoldering patient where multiple myeloma has been in the family, this is another example where I would say I want to be monitored more closely. Like I just, and you just say, I'm sorry, but it's just in the back of my mind, it worries me. I would feel much better if I could be monitored closely, and then talk to your insurance company about it too, to make sure that you don't get hit with any additional expenses. But yes, stay on top of it. Absolutely. I mean, I say this to my kids now that are, in their 30s, like, they're now, we don't have great genes in our family. They have to be on with the internist. They have to know when they're going to get their screenings done, and they have to be on their game. And especially in today's world where, the group that's getting hit hard with cancer now are the younger people. So you want to make sure that everybody knows what they're doing. And I think also, Anne, with the smoldering part, you and I get this question, I'm sure Erin does too, all the time, which is, I'm smoldering, what do I do? And, these are questions that are really important, because when I was smoldering, it was so long ago that there weren't any drugs you could take. And now that whole field is changing dramatically. So you really, if you're smoldering, you really have to know, are you a high risk smoldering patient? How high is your risk? And what do you want to do about that? And again, that is a great time to call Erin and the navigation team to just sit down and say, what is the definition of high risk? Like, that's a great question to go over with Erin, and then go into the doctor and say, I think I'm at a high risk. Like, I would like to talk about how closely I'm being monitored. And then back to the same thing. If I went from smoldering to active today, what would you do? So that you actually start to understand your treatment options. And then we all know how strongly we feel for smoldering patients about all the baseline testing. You need to make sure you're constantly, like, I know what my initial bone marrow biopsy showed. I know what my blood tests are showing. I know what my PET scan was showing. For someone like me, it wasn't like my M spike all of a sudden blew out of the water, but when I did the PET scan, I really lit up like a Christmas tree. And thank God I had a baseline, and it was very clear it was time for me to move. So all those baseline tests and then getting them consistently, really important.
Hear me now?
Yes.
You can. Okay, good. So I wanted to just add there too that for patients that call and think that they are high risk smoldering, that's a really good time to get a specialist. So if you're seeing a general oncologist who maybe doesn't see a lot of smoldering myeloma, there may be a little bit of a lag time or confusion, or maybe not enough information that you can gather. So that's another time that we do navigate people towards specialists if they're considering smoldering or high risk. And then also trials. There are trials for high risk smoldering patients as well.
And another plug for the Navigation Center, I do think that high risk smoldering, to treat or not to treat, is becoming similar to the transplant or no transplant, maintenance or no maintenance, where you have some doctor, based on the very same trial, you have some doctors who say, absolutely, I'm going to treat my high-risk smoldering patients. And then other doctors say, the definition of high risk is highly evolving and it differs from trial to trial. We don't have clear answers. So being able to ask the right questions and also make sure that fits with your own needs, priorities. As Kathy mentioned earlier, some patients do prioritize quality of life. So in that case, it may not make sense if you're high risk smoldering, to pursue treatment, to be continuously monitored. So if it does turn into active myeloma, you can be treated. But it's one of those things where even sometimes second opinions can make it worse, because the doctors may say completely opposite things. So it's really important for patients to have an unbiased understanding of kind of the pros and cons and what makes sense for you as a patient, because this is not a one size fits all disease where everyone gets the same treatment. So I did want to put that plug in there, because there's a lot of buzz around that right now, and there's really not clear answers, even though some doctors may be in one camp or the other.
I think it's also the time and energy. Like, for some patients, the mode of delivery is really important. Like, they may just want all oral therapy, so they don't have to be going to the cancer center all the time. And so there's a lot of reasons why you might pick. Some people might say, I want to be on this treatment option because I only have to have it every so often. So I think that becomes a really important part of the decision too.
Nurses, they're really good at talking through all the different options and making pro and con lists. We talk about that all the time when we're talking about the cases and how did you handle that. We do that a lot because we share tips, but making pros and cons lists, and we do spend over an hour on the phone with people to help them with that. Even just talking it through and having someone listen on the other end. Sometimes people kind of arrive at their own clear decisions just by having that space to really talk for a long length of time. There's no rush. That's the other good thing. We have no length of time. When they call us, there is nobody, there's not somebody waiting in the next room, right? We have plenty of time. So I just wanted to add that as well.
I wanted to go back to the myeloma within family members, because there are questions about screening and hereditary. And one thing, and I think we should just be very perhaps precise with, here's the exact test you should ask. They should ask their doctor for at what time. But for just to preface this with, we often see, we're not sure if it's hereditary or siblings or, you know, parent-child may have been exposed to something environmental, a farm, or, you know, with heavy pesticides or something very dramatic that caused the myeloma. So it may look like it's hereditary, or as Kathy said, that might be the trigger. We don't know yet, but I mean, Kathy, what have you told your kids in terms of what to ask their primary care doctor and when, you know, what they should be screened for or look out for?
My kids think I'm completely neurotic about this, but the most important thing you can do is get your kids to a really good primary care doctor or internist that knows your family history. So ironically, my kids are in their, you know, Nicole's 30 now, but because I'm lucky they live relatively nearby or come back, we actually are all at the same internist. Now, not everybody can do that. So you have to teach your kids, like, you've got to fill these forms out carefully and stay with the same internist. What happens now is everybody's going to urgent care and, you know, running around. They don't have a doctor, and we don't have a ton of primary care doctors or internists in the US. So it's really important to do that. Then whenever my kids say anything about an issue that they may have, I never downplay it. So like if one of them comes to me and they have like a GI issue and they're trying to follow something, like, you know, you might goof around about that. It's not funny anymore because, you know, colorectal cancer is on the rise in young people. So as soon as I hear anything from them, my response is get to the doctor. Get to the doctor. So I never downplay any kind of medical situation in our family. Now, obviously, for our daughter, it's more like now she's going to have to start doing mammograms earlier than others. And, you know, they're just going to have to stay on their game in terms of even doing colonoscopies and things like that down the road. But I do remind them, you know, when you look at your family history, if it turns out like that your mom or your grandmother or your aunt got breast cancer at the age of 70, that does not put you at high risk just because you had somebody in your family have breast cancer at a certain age or multiple myeloma. It doesn't mean you're necessarily always at high risk. I mean, the odds of somebody in your family getting cancer at an older age, let's face it, 1 in 2 or 1 in 3 will be getting cancer. So it does happen. But you really do look out for people that got cancer at a young age in your family. That's like a big red flag. And then tell your kids, like, I'm all constantly going through the screenings, and then they change all the time. So as soon as I see a new screening on colonoscopy, I mean, and again, the vaccines for kids, you know, get them on the HPV vaccine. Like, how can we not do that when it's a great way to prevent certain cancers too?
Erin, and a question came in about resources for caregivers, and Kathy, you may have comments too, because you've been on both ends of this. You know, what resources do you recommend, starting with Erin and then to Kathy, for just not just for dealing with the diagnosis, but also with making sure that they're making time for their own self-care?
Yeah, so luckily now there are more than, I would say 4 years ago, there was not really a lot for caregivers, but people started speaking up, and now there's a lot more resources. So there's education materials that we have at the MMRF. We do have a caregiver booklet, but many of these nonprofit organizations do have caregiver support groups. They have tips of what to do to remember to put yourself first, because that's really what happens is their life gets taken over by becoming a caregiver. So there's a lot of resources that we navigate towards. There's also sometimes counseling. When at the ONS program that I just went to, I learned that there's counseling funds for caregivers, and that's just as important too, not just for patients, but for caregivers.
Yeah, and I would add to that, oftentimes your caregiver is a partner or a child. It's often somebody in your family. And you know, I wrote about this a lot in Fatal to Fearless because it was the biggest mistake I made. And we laugh about it, but it's not really funny that 3 members of my family felt like they deserved an apology from me because cancer took over my life and their lives. And so that was like one of the biggest regrets in the book. So one place that I always recommend now is the Gottman Institute, which is really just about relationships in general. And Gottman used to always be about your partner and how to have good relationships with your partner. But now they actually do a lot of work on parents and children too. And I just think their advice is spot on when it comes to just having healthy relationships, whether you have cancer or you don't. And then for us, we always did like, if you got into a jam and it was a really tough time, we might do couples counseling or something like that. But I actually feel like this is a long journey. It really is. And I feel like rather than doing that on and off, it's better to start understanding how you get better relationships in general and let that stay with you.
Really good advice. A question kind of going back to an earlier topic of communicating with a care team. And I raise this because I remember this being a question on the webinar too, making sure that upfront, we touched upon this, but I think to have an explicit answer upfront, making sure that the care team communicates all of the possible short and long-term side effects, and I mean, also how to best educate yourself so that these things don't crop up years later. And actually that might go into a good topic around dental work and communicating with that. But how do you really make sure that you're getting everything you need to know to not only weigh the short-term risks and benefits, but be prepared for any long-term sequelae as well?
Okay, so I feel like one area, like when you first get diagnosed or when you relapse, is when you're going back on and doing your research. And again, you're going to do your research through the MMRF, you're going to do it through Google. Over time, you're going to start doing it through ChatGPT. We just have to be realistic. People are going to do that. And it's important that we're always, and I'm sure Erin does this too, you're following what ChatGPT is saying and making sure that it's valid for our patients. But it is an easy way sometimes to get some start of information. But I also feel like as you start to understand what your treatment options are, I always say to people, don't go to the .com pages first when you do your Google research, because those are the pharma sites and they are usually paid. But I will say, once you know what drugs the doctor's prescribing for you or what they look like, I think that's a fine time to actually go in and put in the drug name and go to the pharmaceutical site, because it will give you the entire package insert for that drug, and it will tell you the short and long.
Did we lose her? Erin, do you want to pick that up? Erin, you're muted. You're muted now. You're still muted. So I'll pick up on what Kathy was saying. It is helpful, and some of the terms you may not be familiar with in terms of side effects, but certainly Google them, and then all roads end up leading back to the PNC to really talk through what are some of those symptoms, because with some of the newer therapies, even with the CAR-Ts, you may see some delayed onset of some neurologic side effects, which are very unusual, but not all patients are necessarily given those, because you have that short window of treatment, and then you're not seen as frequently. So to know that those symptoms, those longer term effects could happen, and be able to contact your doctor and communicate that is really important.
Can you hear me now?
Yep.
Yeah. Okay. So yeah, so the long-term effects, right? I agree. It's so important to understand the potential of what they could be in a realistic way, because sometimes the percentage of a long-term side effect is really small, 2% or 4%. So it's important to understand in how many people in the research and the data that has been published that it's actually been seen in, just to balance the whole perspective. And then the short-term side effects, this is just so helpful to educate yourself on, because then you can know what to speak up on and what's normal and what's not. And so that quality of life is really important. So not just staying, and that helps you also to stay on a treatment that's working. is if you do have good quality of life and you're sleeping well, that you can stay on that medication that's working so well for your myeloma.
Yeah, certainly don't hesitate to raise side effects, because we're finding too, as opposed to 5, 10, 15 years ago, where we didn't know as much about altering the dose with a lot of these immunotherapies. We found that holding a treatment, holding a cycle, or taking down the dose works just as well as what the FDA approved the treatment for. So it's super important to raise those. But also, again, educate yourself when starting the treatment about short-term and also longer-term possibilities too. We have time for a couple more. I did want to go back to, because this relates both to this topic and also the healthcare team. And Kathy, your experience specifically with dental issues and how I hope a lot of patients know now to tell their dentist when they've been diagnosed with myeloma and what they've been treated with. But how did you navigate some of those challenges that you had?
Yeah, it was tricky because when I was diagnosed, it was a long time ago. And so bisphosphonates were, a mainstay of our therapy, and we were given them in large doses. And then along the way, we realized that there was an element of osteonecrosis that would happen with bisphosphonates. So sometimes it's just part of being the early group on drugs that it takes time for us to learn the impact that they have on patients. But fast forward between bisphosphonates and the challenge of a stem cell transplant and dry mouth, that it ends up giving you a lot of dental problems. So I always say to everybody, not only do you get to the dentist before you start any of your treatments, you've got to be at the dentist all the time. Again, this is like another one. Every 3 or 6 months, you need to be in there. And Erin, the reason this came up for Anime was like, now here I am with I've run out of options, and you get hit with a bill. Like, I'm sitting on a bill of tens of thousands of dollars. None of us have decent dental insurance. I don't know why, by the way, somebody hasn't figured that category out, but we don't. So that's all out of pocket. And so I just think that this is a huge issue in myeloma and all cancers, is the financial burden that we face on out-of-pocket expenses, but people forget about the dental side. And it has actually hit me harder than the medical.
We hear that as well. And there is funding out there, but not enough, certainly not enough.
Yeah.
So I think we have time for one other question. And so someone was asking questions that they may have, particularly about what could happen at the end if a patient doesn't survive myeloma. Who to ask how to get those answers without asking them in front of the patient. Is it the doctor? Is it social worker? Is it how to get some of those answers, because they're sensitive and you may not want to ask them in front of the patient.
So you're saying it's a caregiver sitting with a patient and they want to know, for example, how long the doctor thinks the patient might live?
Yeah, or how to recognize when, the end may be close, those kinds of
questions. So this
in front of a patient.
Yeah, and Erin probably finds this too. Like, in terms of the cost of care, and I think the frustration of care, this is probably one of the most frustrating, is end of life. So there's the element of, like, what does it cost to get people in and out of emergency rooms when they're nervous about their current care and how sick are they? But the second is this area. And I think it's really, again, I'm going to go back to talking to your caregiver and being a thoughtful patient, is you really need to have these conversations with people. I can't tell you how much I say to patients, it's not fair to leave this with your caregiver. It's not fair. It's not fair to leave this with your children. It's not fair not to talk about it. So my recommendation is that we really help patients to understand the best gift they can give their family is to have this discussion. So, like, I did this, like, with my own mom when she had cancer and other diseases. And I looked at her and I said, when do you think it's time to go? And she said, when I can no longer go out for dinner with my family and children and do those things, then I don't want anything done to help me at all. It's just kind of having a conversation with them that says, what is it that's important? Like, a lot of people have done this. What do you want to be able to do? Watch football with my grandson. Like, it could be anything. But when all of a sudden these things start to go, you want to be able to have the conversation. And if you're the medical proxy, and make sure there's always somebody that's your medical proxy, that person really needs to know you pretty well. Otherwise, it's not fair. So I don't think it's left to the caregiver to ask this question in front of the patient. I think it's for the caregiver to work with the patient and the patient to really understand it's important to start talking about it.
You went out again, Erin. You're out again. That's okay. So, and I could just speak a little bit for Erin. Erin also has, before the MMRF, some professional experience in this realm too. So if anyone on the call wants to speak to her further about some of these discussions, it is really an important for the patient to communicate needs, but also if it certainly causes anxiety on the side of caregivers as well, that to reach out as well. So I think with that, we're at time, and I really appreciate Kathy, you, Erin, for joining us today. Thank you to everyone who participated for joining us. I apologize for the technical difficulties. It seems in the beginning when we test everything works perfectly. Then sometimes you get on these webinars or live streams and things don't work out. So thank you for bearing with us. I'd also like to thank the sponsors who made this possible: Adaptive, Amgen, Bristol Myers Squibb, Cure Magazine, Genentech, Johnson & Johnson, Kite, Arcellx, Pfizer, and Sanofi for making this possible. And then I did see the Patient Navigation Center information put into the chat. But certainly if you would like to speak to Erin or one of our other navigators, you can reach them at 1-888-841-6673. There's also ways to get in touch directly from our website. So that concludes today's live stream, and thank you again.